Good evening, everyone, and welcome to the ASPN webinar series focusing on DRG stimulation, the science, technique, and clinical data. We are very glad you've joined us for the webinar tonight. We will start the webinar promptly at 9:02 to give a few more people time to log on. Thank you again for joining us. We will begin the webinar in just 1 minute. Thank you everyone for joining the ASPN webinar series focusing on DRG stimulation, the science, technique, and clinical data. The webinar will begin in just a few more seconds to allow a few more people time to join us. Again, the webinar will begin in just a few seconds. Thank you for joining us. Good evening, everyone. It is 9:02. We are beginning the webinar officially. DRG stimulation, the science, technique, and clinical data presented by ASPN. I would like to introduce Dr. Tim Deer. Dr. Deer and Dr. Chakravarthy, take it away.
Well, welcome everyone. Certainly it's another night of discussion, and tonight we're talking about DRG stimulation, which has been something close to my heart for some time. And my colleague tonight, Krishnan Chakravarthy, joins me. Krishnan?
Yeah, hi everyone. I think we're getting to the point where a lot of us feel like a little bit on webinar saturation, but I have to say, my personal experience, I think this is one of those few therapies that very rarely in pain medicine we can say is a home run. And there are certain times, just recently I had done a patient that had phantom limb pain. I was just talking about that. And till today, he still texts me saying complete pain relief after having almost 18 years of chronic pain that he couldn't really solve with all different types of approaches. So there's one other special thing tonight that for folks that have hopped on, you will see my close friend and colleague and a person I've shared the webinar moderatorship for quite some time actually debate. So I'm really looking forward to Tim actually taking a part in this part of the panel and kind of talking to you about a little bit of a different forum than most webinars, but we're actually going to be very interactive. So I'm going to let Tim go through the learning objectives, and then I'll certainly introduce our wonderful faculty that are committing their time tonight.
Great, Krish. Well, DRG is certainly, of all the things I've done, has been the most life-changing therapy I've offered patients. And, I've had people that have, as you mentioned, phantom limb pain, severe leg injuries, arm injuries, and gone back to a pretty normal lifestyle. So I think in the selected patient, it can be life-changing. So that's our goal tonight, is to discuss those things, look at the science behind DRG, which we'll have some great faculty to discuss the science, look at the best practices and really what you should be doing in your practice. And then we'll look at some discussions around the clinical data supporting DRG, which isn't there for other therapies, to be quite honest. The evidence is what we should always focus on. And the evidence for DRG is so much stronger than the evidence for other therapies that it's fairly impressive in that regard. So with that, Krishnan, let's have you introduce the faculty. We're going to stay right on time tonight for you.
Sure. Go to the next slide. So these faculty actually probably need no introduction. I mean, I think they have been really strong proponents of this therapy for the last 5-10 years, taking their time to probably train a lot of the new fellows as well as other faculty that are applying DRG. One thing I would say is there's a very beautiful sentiment. One of our during the DRG training, Eric Cornitez once said that this is a special therapy that really the onus of the responsibility for the folks that are applying it to really understand the science and the proper technique. And I think tonight, what you're going to see from all of these faculty members today is the passion that they share about this therapy, and they really dedicated their time as well as their research. And I know Tim has really brought this from the beginning to where it is in the US, but certainly I think for the longevity of this therapy and certainly to see it continue to make great impact on patients, I think we can't have a better group today to kind of speak to its value. So we can kind of go through the agenda. Tim?
Yeah, Krishnan. So we're going to start off with Ken Chapman and Tim Lubenow talking about the science and really some of the really new futuristic things we can think about with this therapy. Dr. Mehta and Dr. Carlson can talk about the technique. Clinical data will be Dr. Westbine and myself. Dr. Pope is right now still tied up somewhere in California, undisclosed location, because he's debating Dr. Chapman, and we're not sure he wants to show up for that debate. So I'll be taking over for him there. Then Dr. Mehta and I will talk about PNS versus DRG. How do you make that decision? Two great therapies, and then future research areas of study back to Dr. Chapman and Dr. Lubenow. And then at the end, we'll close with Q&A. And we'll be done at the very latest by 15 after the hour with questions. So if you have questions, please type those in. Anything's fair game, and we can answer, since this is CME accredited, we can answer that any question you may have. So with that, we'll start with our first two lecturers, Dr. Kenneth Chapman, Dr. Timothy Lubenow. So gentlemen, we take it to you.
Ken, we can see you. Are you on mute?
So is Dr. Lubenow on?
Just waiting for Tim.
There he is. There he is.
Here.
Hey, Tim.
Okay, can you
There
guys
we
hear
go.
me?
Yes, sir.
Yep.
All right. Does Michelle want to forward the slides?
Tim, it's all yours. Take it away, sir.
Okay. So before one takes DRG stimulation therapy, it's useful to understand the neuroanatomy and neurophysiology behind this. And the thing that makes DRG stimulation different from others is that this is the one area of the nervous system where all of the sensory fibers are coalesced together at the level of the DRG. And when we stimulate the DRG, we're able to effectively stimulate the C fiber as well as the A delta fiber, as well as A beta and A alpha fibers. And this DRG acts as a low pass filter that can modulate the sensory afferent activity as it comes into the spinal cord. And it can augment this in the scenario where you have neuropathic pain, or it can mute or attenuate the afferent signal as it's coming in with the technique of DRG stimulation. Next slide, please. This is a cross section through the dorsal root ganglion here. The sensory afferent fiber here really exists as a pseudo-unipolar axon with a very long axon that starts in the periphery, travels up to the dorsal root ganglion, which sits at the level of the neuroforamina, and then there are sensory dorsal root projections into the spinal cord. And this is just the typical pattern of how sensory afferent information comes into the cord. Next slide. There's a specific somatotropic arrangement to the DRG. What we have here is a cross section through the DRG of an animal where one fiber, let's say the L5 nerve root or the femoral nerve, was injected in red, and the sciatic nerve was injected in blue. And then you take a cross section through the L4 nerve root, and you'll see there's a specific way in which the femoral nerve fibers are coalesced together, different and distinct from the sciatic nerve fibers. Next slide. And so this is a typical path that the signal usually travels. It comes into the dorsal root ganglion, projects into the spinal cord here. And if you were to transect the peripheral nerve in an attempt to alleviate pain, you look at this first EMG recording here, depicted in number 1, and you'll see that it doesn't do anything to the electrical signal. The electrical signal still continues on. If you transect the nerve rootlet here proximal to the DRG, between the DRG and then the spinal cord, you'll get electrical silence there. And so this goes to demonstrate how important the role of the DRG, the dorsal root ganglion, is in this synaptic transmission of pain. This next slide shows the information. It shows the difference between injured population of neurons off to the right and the normal population of DRG neurons. In the injured DRG neurons, there is a threshold of activation that's less than the normal population of DRG neurons, and the injured DRG neurons will get stimulated at about 2/3 or 1/2 the amplitude that one usually requires to stimulate a normal DRG axon. We use this to our advantage in DRG stimulation because we intend to stimulate only the injured neurons, and we employ a paresthesia-free form of stimulation. That is, the amplitude of stimulation is always low enough, soft enough, that we don't induce paresthesia in the extremity that we're stimulating. Next slide. This is a animal study, and what it demonstrates is if you put a recording neuron into the dorsal root ganglion and then send a signal, you'll get a specific signal in the injury right there. And then if you were to employ DRG stimulation for a certain particular time frame, you're going to take this abnormal firing of electrical activity and you're going to turn it down to this smaller, less frequent and muted amplitude of signals. And so this is just an electrical representation of what happens with DRG stimulation in the animal. Next slide. Dorsal root ganglion stimulation is intended to be employed at the level of the DRG here, and what it does is modulate synaptic transmission as it comes into the spinal cord. Stimulation causes both an antrodromic and an orthodromic effect that is up and down the central neuraxis, and Dr. Chapman will talk a little bit more in detail about that. Next slide. And so, in summary, what we do with DRG stimulation is we're going to insert a needle, employ a introducer, and then insert an electrode that cradles over the dorsal root ganglion, and we're going to stimulate this collection of sensory afferent neurons in our treatment to modulate pain. Next slide.
Hey Tim, this is where I was going to take over. Can you pass out? Can I get the screen so I could use the slides from my computer?
Ken, I'm going to go ahead and just keep driving just so we don't have a technical.
Okay, no problem. So great job, Tim. I'm going to talk now about the effects of DRG stimulation. Not what happens within the dorsal root ganglion, but the upstream effects of what's going on within the spinal cord from what we're doing at the dorsal root ganglion. And is what this treatment, DRG stimulation, is a treatment that really, when we call ourselves neuromodulators, this is what it was about, because we are truly able to modulate and change the signal to the signal that we want to get into the spinal cord. Okay, so we have, actually, next slide. You know, and I got to talk about a little bit about the basics before we can get into what's happening here. And as many of you know, there's 4 major fiber types, really 3 when it comes to sensory. But within these categories, there's multiple sublayers of categories of cell types. And those nerve fibers respond to different types of stimulation. We have essentially high threshold mechanoreceptors in both our A delta and C fibers and low threshold mechanoreceptors, and they're found in different parts of our body. And you can see here we've kind of highlighted their role, and it's not just for pain, and we typically think they're pain fibers, but they're also light touch, non-noxious stimulus fibers that are found on our hairy skin. Next slide, please. So, you know, in being able to adjust and change the nerves traveling inwards, we need to kind of understand how those nerves themselves transmit signals. How do they say scratching your skin is worse than, you know, putting a knife against your skin? It's the same fibers that transmit those signals. And as we know, that we can't change the amplitude of an action potential. So the way that nerve fiber is going to change the message that goes in is through frequency. And that frequency is going to determine what message is being relayed at that next level. And as you can see on that slide there, different frequencies, you can release not only different amounts of neurotransmitter, but also different types of neurotransmitter. Next slide, please. And so there are fibers within our body that are meant to inhibit, and that's why we have opioid receptors. That's why oxycodone works and Vicodin works, because they work on receptors that our body naturally has to inhibit pain. And so why do we have those? And it's listed right here. It's lateral inhibition. That's one of them. And within our skin, to fine-tune the touch process and to localize pain, especially when you couldn't see it, and say we were hairy animals and you get a thorn stuck under your skin, we get lateral inhibition. We get inhibition around the central focus of pain. That inhibition is partly due to our body, to the endogenous opioid system. And so we could fine tune, and you really could get specialized as far as what kind of sensation you're feeling. Next slide, please. And so, okay, so that's a little about just the way nerves fire, but let's think about what happens now when these messages come into our spinal cord, right? So we think that our L4 comes into, where does our L4 enter our spinal cord? Or where does our L2 enter our spinal cord? And here's a cadaveric study. You know, they come up and our L2 is going to be down at the bottom of T11, okay? And then 3, 4, 5 will go from T11 to T12, and then S1 will be below that. Next image. And so, as I just mentioned, here's an image of a T12 spinal nerve. And hold on one second with the advancement of slides. The our T12 spinal nerve is actually going to enter our spinal cord down at the bottom of T10, 11. And those little fibers that we talked about, those low threshold mechanoreceptors that are responsible for a lot of the touch we feel, you know, they enter at that level and they form collaterals at every level. And that's why when we use dorsal column stimulation, we hijack this system. We drop electrical stimulation in the middle of the system and spread it outwards through this collateral network. Next image. Whereas with A beta and C fibers, these are going to travel up 1 to 2 levels, and they're precise. They're going to be dropped right at one point, right at the end of the nerve, and that's the only input that they're going to have. Next image. And we also have to consider, when we're thinking about where our nerve fibers are ending, is we have this thing called Lissauer's tract, and certain nerve fibers come up and down in there, including our A delta and C fibers, which are both pain and then this mechanical touch sensation. Next image. And you know, as Brown-Séquard syndrome is a classic example of that. And so when our nervous system sends these messages, they do it in this frequency dependent manner. But not only that, our nerves, we have certain nerves that only respond to certain frequency stimulation. So here's an image from Arcourt's paper. It's an optogenetics study. It's really amazing. Optogenetics is an absolute amazing field to get into if you were to be a PhD. But they would stimulate these fibers, these inhibitory fibers, and up to a certain degree, and you can see there at 20 hertz, it'd be 1-to-1 stimulation. After 20 hertz, it drops significantly, and after 40 hertz, even more. Next slide. My next image. And again, these fibers at these low frequencies are going to cause release of certain transmitters or ligands, and these fibers in particular have the ability to release endorphins. Next slide. And so our normal processing in our spinal cord, okay, this message comes up, we have our A delta and C fibers, we use substance P and glutamate, it's going to activate that secondary neuron. We have an inhibitory forces from our A beta fibers. Next image. And then you have other blocking systems, including descending inhibition, and that's where norepinephrine, serotonin get their messages from the locus coeruleus and rostroventral medulla. That's where these medications, that's where we use a lot of medications that act within the spinal cord. Next image. Next slide. And so now if we put, backwards, I'm sorry. Can we go back to the last slide? So now this just kind of sums up what I was just talking about. On these hairy fibers, on the hairy skin, we have certain nerve fibers that can inhibit, nerve fibers that inhibit at less than 20 hertz, nerve fibers that use our body's natural endogenous opioid system. So what we're doing with DRG and what we have the capability to do is to take over what our body is sending from the outside to the inside. And that can be pain, that can be motor stimulation, that can be the inhibition of pain and the feeling, the nice sensation when you rub your arm and someone gently caresses and tickles the hair on your arm. So DRG allows us not only the effects at that DRG, but to fine-tune the mess or control the message that's coming in, depending on the frequency that we're sending it. Next slide. And you say, well, what are the differences? You know, there's been a lot of good work done recently on some of the basic science behind DRG, and is it different? And I would say absolutely, and we need more basic research to prove that. And here I have a couple studies that were done recently. Here's the list of many of them are out in the Netherlands, except a couple of older ones, and Dr. Levy's. The first column graph up here, they use dorsal column stimulation, baseline allodynia. They had allodynia, and if essentially at 50, I forget what the number, 200, and then 1,000, you would get the inhibition of mechanical stimulation. But then when you would measure at that time dorsal column stimulation, you have an increased GABA level within the dorsal horn. DRG stimulation, they were able to get the same inhibition of pain, but and they were effective at all levels, but only at the very low levels where we really were able to get great carryover effect. And not only that, it was shown that GABA wasn't elevated in these levels. I mean, these were done in rats and these were done in certain settings, which may or may not be reflective of humans, but ultimately it works, and we are able to do this at very low frequencies and then get a much longer potential carryover effect. And there's also potential for less habituation based on data taken from the ACCURATE study. Next slide. And so this is a study that we've done that is soon to be published, where we titrated. We said, well, if these receptors are responsible for inhibiting pain, and these low threshold mechanoreceptors that use endorphins in humans function from 0 to 5 hertz normally. These are 0 to 5 hertz they work. Why don't we try to taper down some patients? And so we tapered patients from, we had 20 patients tapered from 16 hertz down to 4 hertz. And we had actually no change in NRS, ODI, or EQ5. So essentially, we're able to provide a dense inhibition, very focal inhibition within the location where we want in the spinal cord with extremely low frequency stimulation. And the charge per second that we're delivering to the cord is absolutely, more than 1,000 times to 1,500 times less than with other methods. Next slide. And so something different is going on, because we all know that if you put 4 Hertz on, it wouldn't help, or be unlikely to help on the dorsal column. So what we need to do is we need to all work together to keep pushing the envelope and help decipher how to best help our patients by helping their pain, function, quality of life, and psychological status. And that's it. Next slide.
Tim, you're on mute.
I haven't done that in a while. So you've set the tone for why the DRG is so unique. And I think that's great because it's so much better than other targets, Ken. A great discussion on why. And Tim, thank you for the kind of overall view of why it may be a target. Now we go to how to put the lead in a safe, efficient fashion. So for that, we go to Dr. Mehta, Dr. Carlson. Gentlemen.
Thank you, everybody. I think that was a great information about what the DRG is. Next slide, please. So I'm going to talk about the DRG technique, the steps, and kind of quickly recap of what a lot of the audience on this webinar have probably tried or are trying to get more cases and become more proficient at it. Dr. Carlson, my good friend, is going to take over for the lower distal lumbar L4, L5, and then the sacral placement. But essentially, if I had to kind of go over all the steps of how to get DRG modulation going, then you can see here on the slide, you locate your spots on the skin where you're going to put the needle in, prepare your delivery system, you advance your lead and your sheath, position the lead, and then create the most important part of the procedure, which is anchorage, which are the loops. And then obviously, if you're doing a trial, you can remove the system. If you're doing an implant, you can move ahead and do the implant. Next slide. So just going on over that same framework, the first thing really is positioning, right? So look, we've lived in the epidural space for years. One of the first things to do, we all do, all implanters or neuromodulators or all surgeons, is to make sure the position is proper. And so the goal here is to eliminate the lordosis. This becomes even more important when you're doing an L4 in the L5 area, where the dura is a little bit more closer to the skin than in the other areas. And so the first thing to do under fluoroscopy is to mark 3 dots: the skin entry, which is a contralateral approach, the epidural entry point on the fluoroscopy, and then your target DRG. And when you do that on the patient, before you go into the OR, you'll find it to be a straight line. So that's what it looks like. So if you look at the first picture on the left side of the slide, that's your 3 dots, right? So you have your target DRG. In this case, which is going to be the right-sided T12, right, for possibly a groin case. And then you have the needle and dive-in spot of the needle in the epidural space at the T12 L1 interlaminar spot space. And then you have the contralateral pedicle at L2, which is your skin entry spot, and follows a straight line. So obviously the first step is to gain access into the epidural space. So this is an intraspinal access which you have to get. And then you park your contacts over your target DRG. So if you look at the picture in the middle part of the slide, you get a loss of resistance, whichever way you're used to in your practice, to saline or air, and you make sure that you have an optimal angle access into the epidural space. What does that mean? You want to make sure that your lead as it enters, or your delivery system as it enters into your epidural space, is posterior in the epidural space. So that's the first thing we got to confirm. And really the second step in the question is, what is the delivery apparatus? So if you look on the right-hand side of the slide, you'll find this sheet, which has got a larger curve at the tip of the sheet. So there are 2 sheets which come in the packet. Or the package. One of them is a larger curve and the one of them is a smaller curve. I've never used a small curve except for a few cases when I'm doing sacral neuromodulation. But I always use, almost always, the lumbar in the larger curve sheets. And you can see here that at the bottom part of that sheet is a lure lock, which you have to really tighten to make sure the lead doesn't slip in and out of that sheet. And what that means is that when you've actually tightened it, and you're sure that it's completely tight, you have 2 more rounds to go. So this is something you can practice when you have the kit, or take a little pause when you're about to gain access into the epidural space. Next slide. Once you gain access into the epidural space, you can see here in the cartoon as well as on the X-ray, you use your sheath and your lead combination. So the lead is inside the sheath, which is your conductor or your driver, and is going to help you drive the contacts underneath the pedicle. And you can see that on the fluoroscopy picture on the slide, that once you have parked that, the job of the driver or the job of the sheath is done. And so when the job is done, then the driver or the sheath has to come back. Now look at the left-hand side of the slide, and you'll see that the slide, the sheath has been retracted back into the bevel of the needle. Next slide. So, like I said, you look here at the cartoon here, you've used your driver or the sheath to park your contacts underneath the pedicle. And then once that's done, then that red arrow, which brings the sheath back to the bevel of the needle, that's the next step. So what that does is it helps you prepare for the next step of the procedure, and your contacts are already deployed over the target DRG. Next step, next slide. So what does that look in terms of fluoroscopy, right? So here are your contacts which were originally deployed. Your sheath came back to the bevel of the needle. And as soon as it comes close to the spinous process, which you see right on the slide, you turn your system in such a way that your needle bevel and your sheath are all looking at north or 12 o'clock position. How would you know that? You look at the small little extension which the sheath has, which allows you to do a clock indication when you're trying to face the sheath in a certain direction. Once you've done that, you use your sheath back again to push and drive the lead north or towards the 12 o'clock position for a few millimeters. And when you see the loop form or the top loop form, the job of the driver is done, and that driver comes back to the parking spot. But keep in mind, look at the picture here on the slide. When you reach the end plate of the next vertebral level, which is in the top end plate level, you see how the leads are going to get sucked in and wrap around the medial border of the pedicle. And that's your final position, because the middle two contacts are over your target DRG. Next slide. Now, once that's done, the top loop is already formed. The next step is to form the bottom loop, and you turn your needle and your sheath towards 3 o'clock or 4 o'clock position relative to the lumbar spine. Next slide. And once that's done, really then the job of the driver comes into action. The driver drives the lead at that 3 o'clock position so that you form the bottom part of the S loop. And once that's done, the job of the driver is done, so you can pull the sheath, aka the driver, back to the bevel of the needle. Next slide. So you can see here, there's a nice, beautiful top loop. The contacts are wrapping around the medial border of pedicle. The middle two contacts are on the target DRG, and you have a nice bottom part of the S loop. Why are these important? These are important because they serve as the most important step of anchorage for your contacts, which you have worked so hard to deploy at that target DRG. Next slide. Now, the steps recommend doing a lateral X-ray at this time. But honestly, anecdotally, I can tell you can do a lateral X-ray at any step to make sure that you are dorsal in the epidural space and you're dorsal in the foraminal space. Looking at this was done at the end of the procedure. And because the contacts of the lead do not cross over the posterior border of that vertebral body, it is a very classically nicely done a dorsal placement of the contacts in the foraminal space. Next slide. And with that, that's the skeleton for T10 to L3. I'm going to pass it on to my really good friend, Dr. Carlson, who's done hundreds of these cases, to talk about the differences in when you're trying to do the same thing at the most distal part of the lumbar spine. John?
Thank you. I appreciate that, Dr. Mehta. You did a great job. Again, the on-label indication for this is T10 to L3. And we saw what it should look like in the lateral view as well as in the AP view. Your entry point at the L4 and L5 is going to be slightly lateral, depending on where you're going, slightly lateral to the S1, S2 shadow is what we call it. And it's kind of different than what we've learned from traditional stimulation, where we have about a 30-degree angle when we place our needles. And if you place your needle angle too steep to the body of the patient, then you'll often have your lead go anterior. Well, that's very different at L4-5 with DRG stim. Your needle angle sometimes greater than 45 degrees and sometimes even higher, depending on the size of the patient. And it's important to know. The key is that when you have your epidural entry zone, it's going to be slightly lateral to midline on the contralateral side of your target area. And you want to enter in the superior 50% of the inner space, because that will allow you to set yourself up and stage set yourself to be in the posterior aspect of the foramen when you look in the lateral view, or the dorsal aspect of the frame when you place it. Again, if you place ventral or anterior, you're going to get motor stem. And we'll have the next slide, please. And here's just another example of the same exact slide, just another way of looking at it. Again, your target area, let's say it's the right L4, DRG, you're going to be slightly lateral to the S1 or S2 foramen, and your entry point is going to be very similar if you entered at the L5. So what's the difference at L4 and L5? You have more of a lateral approach and a steeper needle angle than you would at the T10 to L3 levels. Next slide. So why is that different? Well, it's because of the location of the DRG at the L4 and L5 anatomically. The DRG is slightly more lateral, and you can see here in this cartoon, slightly more lateral, this purple part, and it's lower in the foramen than you would see at the T10 to L3 levels. Next slide. So here's an example of this. So you look on the left here, T10 through L3, we have a proper placed lead superiorly. At the L2, L3 level, you can see it's kind of tight to the pedicle. And then you look over here on the right, the L4, L5 level, you can see that the lead is lower in the foramen than traditionally would be, and it's not up against the pedicle. Now, it's okay to get near the pedicle to L4, L5, but just remember that your DRG is going to be slightly lower in the foramen to L4 and L5 and slightly more lateral. It's a good way to show that contrast. Next slide. Same example here. You can see here on the left of L4-5 proper placement. That on the left image, you can see that the lead is slightly lower in the foramen and slightly more lateral. And this is the key here. You remember Dr. Mehta said that you really don't want your lead in the T10 through L3 level touching the vertebral body. You can look at that L5 placement on this image on the right, and it's touching the vertebral body. Traditionally, T10 to L3, you're going to get motor, and if it's placed in your anterior in the foramen, you're getting a motor stem. But that's not the case for what we found at the L4 and L5 level. Often, if you can have if your leads are there, then you'll often get DRG stem, and so you don't have to worry as much of being too anterior at the L4 and L5 levels, because again, the placement of the DRG is more lateral, and it's also lower in the foramen. So this one would actually be okay to accept in a lateral view, but if I was up at T10 or T11, I would not take this, because more than likely I would get motor stem because it's too ventral or anterior in the frame of the lateral view. Next slide. So another example of your entry point, going to the contralateral side, your target area. Again, your epidural access is going to be in that superior 50% of the inner space, and your epidural access is. So next slide. And yet another example here of that more lateral and lower placement of your leads because of the placement of the DRG. Again, it's okay if you're up against the pedicle, but it's not as critical as it is when you're in higher levels. Next slide. So let's talk about S1 and S2 modulation. When we were taught by our friends across the pond in Europe about S1, S2, a lot had said, well, we don't do S1, S2, and there was a lot of reasons for that. The main being that there was migration with these leads when they were doing this in Europe. But we found through the work of many different people, Jeff Rowe, Pankaj Mehta, Tim Deere, and Ken Chapman, that we actually were able to really do well at the S1, S2 levels. And so it was kind of a team approach. Our friends in Europe and Australia, as well as here in the US, we found that we could do a transforaminal approach. Typically, the place we found, because there's variability in the DRG location, is that you want your first contact just ventral to the border, the anterior border of the sacrum. Your final deployment, it might be right at the border, the ventral border of the sacrum. Next slide. So again, the key difference is we talked about L4, L5. S1, S2 is a transforaminal approach. Next slide. And talking about the strain relief loops, I want to mention this was published in Pain Practice by Dr. Chapman and his colleagues in the Netherlands. I think this is a great example. I encourage you to read this paper. It's a really good way to walk through the placement and making the strain relief loops for the S1, S2, S3 placement. Next slide. And I like how Dr. Mehta said, so when you're placing this in the sacral region, S1, S2, you're going to place your needle, and then you're going to take, again, as your driver, your sheath, to go place the lead. And that first contact, again, you can see, it's hard to see in that image A, that first contact is setting just outside the anterior aspect of the sacrum, the ventral aspect of the sacrum. And then you back out your sheath to where it is in the cartoon part A, and then you're going to turn your sheath cephalad or superior, where you're pointing up, your needle and your sheath pointing superior, and you can see that in B. And you're going to advance lead. It's important at this point, I should mention, kind of backing up here, you need to pull out your stylet some, but you're going to advance the lead. And you can see that when you advance the lead, you're going to create that loop within the sacrum. It's hard to see, but in C, you can see a loop starting to be made. Next, what you do, you turn 180 degrees, again with your driver or your sheath, going caudad or inferior within the sacrum, and then you also push it out a little bit, your sheath out a little bit, then you use that to advance lead independent of the sheath, and you can see your second loop is made. When I do this, and several other colleagues who are on this call will do this, I will do one more just as a safeguard to ensure that there's not migration, and I'll turn it one more time, cephalad, to make a third loop. So this is a great step-by-step play on how to do this, and again, this was published in Pain Practice by Dr. Chapman and his colleagues in New York, as well as our friends in the Netherlands. I think we've talked about this earlier and how to remove the sheath. You do need to pull out stylet. Next slide. So let's talk about troubleshooting very quickly here and mitigating lead migration. So I'd like Dr. Mehta to, since he's one of the world experts on DRG, he does more than probably anybody I know, him and Jeff Rowe. Of course, Ken Chapman does as well. But let's just say, Dr. Mehta, if you can't access your target DRG, what's the first thing that you would do? You there, Dr. Mehta? Okay, well,
yeah, I'm here. Sorry, I'm here. I'm trying to, the voice was not clear. What was the question again, John?
What would you do if you can't access the target level? If you're having issues with getting your sheath and lead into the target level, getting to that lattice of ligaments to properly place your DRG lead, what's the first thing you do? And I'm kind of stealing it. It's right here on the sheet, but I like it.
Yeah, that's exactly what it is, bail early, bail often. So, the very first step is that if your needle is not in the right spot, take it out of the epidural space and reinsert. The epidural space is pretty forgiving if you follow the rules. And then if you're not able to reach the target DRG, you kind of do a little troubleshooting step. And you change your angles, make sure that you're dorsal in the foraminal space. And if you're still not able to do it, then I've gone to the adjacent level, if that's really the only option. Sometimes scarring and other anatomical nuisances, like I say, are beyond your control.
I think that's a great answer. And that's something that's important to note. There's some of these patients, especially a lot of them will come to us, they've had podiatry surgery, podiatric surgery, and they maybe even have an L4, L5 fusion, but they're coming to you CRPS issues with their foot. But L4 and L5 are all scarred up. So one of the things to remember, because of multiple levels of convergence of the fibers of the DRG, it's important to know that we've seen it where if you can't access a certain spot, you can go to an adjacent level. We've seen patients get foot pain relief with the DRG placed at L2 or L3, even though we couldn't access L4 and L5. So it's important to know that it's very different than what we think of. Well, you have to have the paresthesial coverage and in the order for the patient to get relief. But we tell the patient, look, don't pay attention to where you have the paresthesia. Pay attention to whether or not you're getting pain relief. That's very important. In the essence of time, I'm going to jump to migration. Myself, I think of my colleague Ramo Naidu, who does a lot of DRG as well. I do 3 loops. I don't just do an S loop. I'll do a third one. I find that I have less migration. But this is a big question, anchoring. Ken Chapman and colleagues, Dr. Lubenow, are working on a study. I think it's very interesting. Should we start to anchor these leads? And I'd like Dr. Chapman, if you're okay, to jump in real quick and kind of give us a really brief what you found. And this is preliminary data; it hasn't been published yet, but obviously you can see quite a bit of remarkable difference between not anchoring versus anchoring. You're still on mute, Ken. Ken, I think you're still muted.
John, you may want to.
Sorry,
go ahead.
First it was the organizer. That was me. When we started, we didn't anchor our leads, and over the first 25 or so patients, we noticed a very high migration rate, and so then we changed our technique to start anchoring our leads. And I always kind of had this feeling that anchoring was the issue. And speaking to my functional neurosurgeon, Elan McGillner at NYU, is a great surgeon, a great physician. I said, hey, if you experience this, and he did the same thing. This is a functional neurosurgeon, that's his only job. And he said, yeah, I did the same thing. And you can see there are migration rates. I think the more important numbers are the migration rate per lead, because some physicians tend to use more leads than others, and that's not necessarily bad. But you can see that the migration rate from 13.3% per lead to 0.6% is massive improvements. And this is in 103 total patients. And there are other reasons for that, which they may be higher, they may be lower. As many of you know, we use T12 DRG for back pain, T12 and S1 for back and leg pain, and so we'll typically have 4 leads. But you can see that there's a clear improvement here, and the lead fracture rate. This data is actually old. The lead fracture rate is actually ticked up. The migration rate has pretty much stayed the same. The lead fracture rate has ticked up a little bit. So I think this is something that we all need to consider, because sometimes there can be a sense of over confidence and in that stress relief loop, but it's the migration as well as where you put these leads, because there was also this last thing I'll say, there's also correlative data as far as the distance from the generator to the lead location, which has been shown long ago by Kumar that's important, as well as where they are, because our T12 and our L3 are the 2 parts of our spine where we experience most rotation. Thanks, and I'll send it back to John.
We'll let Dr. Chakravarthy take it from here, and covering the data.
So the next part, I'm going to actually bring Tim and Jackie on. We're going to kind of go through this as efficiently as possible, and then we're going to start having a fairly interactive session. So I think Dr. Pope had some issues getting on this evening, but Tim and Jackie, take it away.
Well, thanks, Christian. We're going to be pretty efficient here with the data, because we want to get to the few debates here and still stay reasonably on time. So we'll finish around 20 after the hour, hopefully. Listen, I just want to talk just briefly about the ACURATE study. Many of you know that study led to FDA approval, but I want to make some points you may not have heard before. One is, every doctor in this implant study for ACURATE had never implanted a DRG lead before. The results were amazing, the best outcome of any study to date in neuromodulation, but everyone in that study was implanting their first, second, third, fourth, fifth lead. So when someone says your outcome can't be good until you've done quite a few, that's not true. If you take care and time, things went well. Here are the endpoints. We'll go to the next slide. Efficacy and safety were the primary endpoints. And we see at 3 years and 3 months and 1 year, the efficacy remained great for high responders, having 80% pain relief for more. That was, again, the highest number seen to that time, and still in the top 2 studies of all time. But it's been reproduced in the real world. And I think when Ken Chapman spends a few moments talking about gutter stim, what you'll find is it's never been reproduced in the real world, ever. There's only been 1 study that was poor. There might be one study that comes out positive later, but that kind of shows you what is important going forward. And there's proven superiority over conventional SCS even before we get to gutter. Let's go to the next slide. So there's consistent data across the world in multiple places. And then these are industry sponsored studies. For the most part, these are independent studies, some of which were placebo controlled, many of which were randomized controlled studies where there's comparative arms. So there was 920 patients when this slide was made. Now over 1,000 patients in level 1 or level 2 or level 3 studies over now up to almost 10 years. So we're getting to a point where we've really shown the efficacy. And what we have to do from that is learn from that. I mean, we have to learn who did well. Next slide, please. Now, what we did, we looked at other therapies. And again, you look at, DRG, L5 up to T10, around the world and in the United States, we often go up higher levels. And again, the labeling for a company that makes the devices to T10, but Dr. Chapman and I were discussing earlier, and I know Dr. Lubenow was on here, we've often gone up to the high, the lower cervical spine, thoracic spine, and had great outcomes and really established people with terrible arm injuries and other injuries of the brachial plexus, the thorax, the hand. I think I have 2 scheduled next week for hand amputation. So, but when you compare that to nerve root stimulation, when you put the lead, a normal lead out the area, when you look at Dr. Weiner's study, where he put a transfemoral lead in for a number of weeks and took it back out, or if you look at DRG stimulation, there's no question the number of patients in prospective randomized studies, DRG is superior. And that's not me giving my bias, that's just objective data. If you look at the pooled analysis, if Jason were here right now, I think he would say this. This is a study that myself and Dr. Haugen did with Dr. Calaward and other colleagues around Europe, looked at a pooled analysis. And I'm going to cut to the chase. Other than pain, the VAS score and the numeric pain rating scale, there was marked improvement in all the other factors with DRG. So it's really meeting all those new Promise 29 type criteria for a good outcome. And that's in multiple studies in multiple disease states. Next slide, please. And what I mean by that, when you say multiple disease states, here you look at 12 months. This is looking at the data. It's in people that have had causalgia, people that have CRPS, people that have failed back surgery syndrome. So we talked about T12 for back. Our very first study in 2011, which was an acute study, showed back relief. Even in 2011, those patients, we had back relief. So it's not just for causalgia and CRPS, although that's what the labeling was for in the US. It's also for a lot of other indications, which we're going to get to in the last 10 minutes of this program. Let's go to the next slide, please. So safety-wise, again, one of my good friends, Steve Cohen, took the MOD data and published that. If you look at the MOD data, and I talked to Dr. Huntoon, who's a friend of mine, I don't think that paper should have been published without comment, because MOD data says right on page 1 of the FDA landing strip, you can never use that for data analysis, ever, because it's not accurate. This is accurate. This is FDA required reporting. Looked at the safety. Next slide, please. We looked at consecutive patients over the course of time, over a few years, and what we found was the incidence of DRG complications and that of SCS were the same. Now you may say, what about that Denmark study that just came out from Denmark? And I went to Denmark, I've been to Copenhagen, I've implanted there. And one of the authors, Dr. Leon Leem, was with me in Holland, and we did some surgery together in Holland. I had the privilege to scrub in. And what we found was those were different leads. They were ball tip leads, and they didn't really have the care that John Carlson talked about of having the loops. And they weren't anchoring like Ken Chapman talked about. So there's a lot of things. If you do things with care, you found the complication rate is exactly the same as SCS. And many of you on this webinar tonight, a couple hundred people, you've done SCS your whole career. So if you can be just as good with DRG, having done very few initially, that's pretty impressive. But you do have to be a student of the game and do what Dr. Mehta and what Dr. Carlson said. Next slide, please. And here's the safety results compared to other things, including gutter stim, which has a much higher complication rate. No one in the right mind would ever recommend that, I don't believe. We'll find out a little bit later. Next slide, please. And so with that, Dr. Weissman, I give it to you.
Thanks, Tim. I'm going to also go quick in the interest of time. So we're going to talk a little bit about like reproducing these findings. So the target study basically looked at a post-market study of 45 different centers across the US, basically tracking patients from 2016 to 2019 to see how they did. And then at some point they needed to see, could we improve patients' quality of life? Let's see if we can track this. And they introduced the Promise 29 and followed about 50 patients with that for 12 months. Next slide. So these are the demographics, mostly women, but that's not something that we think is different. I'm gonna not focus on this a lot because we're gonna move on for the sake of time. But what we wanted to see was the effect of pain interference. So next slide, please. So one of the first things that we were trying to study was the effect of pain. How much does pain interfere in your life? And what you can see is actually something that's really important on that graph to the right. So you can see that at baseline, prior to DRG stimulation, these patients were able to do less than 1 day a week of exercise, some of them none. And that was a good portion of the patient cohorts. But at 12 months, you can see that those colors completely flip. And that's because at 12 months, the majority of patients were able to have a significant improvement in their quality of life. And you can see they were active more than 1 to 2 days a week, some even greater than 5 days a week, more than at baseline. Next slide. So these are graphs looking at 3 different variables regarding psychosocial, emotional variables, things like isolation, anxiety, depression. We all know that these things are affected when patients have chronic pain. 72% of the patients who were moderately or severely impaired at the beginning of the study, you can see improved significantly with regard to their social isolation. 38% reported an improvement in their anxiety and 25% in their depression. I think those are significant things, particularly when these people are completely, their lives are turned upside down by this kind of chronic pain. So if we can move to the next slide. When we think about how those things affect patients, we think about the impact on their daily life, right? And you can see that over the course of the study from baseline to 12 months, there was a significant positive impact on the pain with regard to their daily life and functioning. And that means that we had a significant satisfaction with the therapy. Over 75% of these patients regarded their treatment as satisfactory or very satisfactory at the end of 12 months. Next slide. So basically at 12 months, we had patients with improved physical function, increased social participation, less depression, anxiety. More importantly, I think to Tim's point, this was something that was reproducible, right? So we have a lot of studies where we see things that we can't really reproduce in the office. Again, these are reproducible things that patients can benefit from all across the world and country. So thank you so much, and we're gonna keep moving.
Awesome job. All right, so let's we're gonna try to do these debates, and I'm gonna just introduce our 2 folks that are gonna be debating, Ken and Tim. So just to preface this, you've heard from now probably all of these experts about how amazing DRG is from mechanism. We went through certainly technique, and now we've gone through the clinical data. But here's the challenge. There are a lot of pain practitioners across the country, and today the issue is not everybody has access to the data, and certainly there are people who are practicing all different types of approaches. And part of the onus of this debate between these folks and these wonderful gentlemen is going to be trying to really be respectful of the opinion, but ultimately really driving why data should help us make better selections in terms of these types of patients that we think clearly this technique and this therapy has been very well validated. So I'm going to start with my good friend Ken, who's going to now try to present a quick but fairly robust support for gutter stim, and then I'm going to let Tim take Jason's spot and try to say why he agrees or disagrees, and certainly says why DRG is a better option. Not that I'm biased, actually.
Well, since Tim's been setting the stage for this all night, I will let him at least begin by giving a little bit of history of gutter stim to further establish his position, and then I'll present my part. Is that okay, Tim?
Ken, we were actually running really late. We only have a couple minutes apiece, so I'm going to defer to you as a gentleman. You get to go first. I'll go a couple of minutes. We have about 5 minutes total. So go ahead, sir.
So gutter stimulation, and the reason I wanted to bring this up is because gutter stimulation, and they call it the gutter for a reason. And when we used to use tonic stimulation, if your lead migrated, it went in the gutter, and then the patient had pain. And so the gutter was always known as a bad place. And I had a slide earlier I didn't present, but it talked about the evolution of stimulation. And there was a moment that's neuromodulation changed before DRG, and that's with subthreshold stimulation. And with burst stimulation, putting your lead out laterally isn't necessarily a bad thing. And if you can get it in the right spot, you can catch multiple nerves instead of just one DRG, and potentially have benefits within the dorsal horn. And within the dorsal horn, that's where our inhibition is occurring. So, while we don't have the fine-tuning capabilities of DRGS, I think it is something that can be used. In particular, if you don't have or don't really perform that much stimulation, it's something that could be tried first.
No, Ken, I think your last comment was really accurate. If you don't do much stimulation and you're not very good at it, it's a reasonable thing to try. If you're actually talented with your hands, someone recently posted on LinkedIn something ridiculous. They said, well, I can get 4 DRGs with a retrograde gutter stimulate. Well, we did retrograde gutter stimulates back in 1994 because, people were incompetent. So you can't get 4 DRGs. You might get some nerves, but the soma of the DRG is in the DRG. The soma of the DRG isn't somewhere in that gutter. So you might get lucky and get something for a while, but this debate doesn't come down to what you think or what I think or what Krishnan thinks. It comes down to data. There is no data right now for gutter stim. There's one article that's terrible. There's a company-sponsored article right now, which is off-label for any company in America to talk about gutter stim. But there's a company-sponsored study, which I'm not optimistic is going to be very fair, and then it can't be reproduced, in my opinion, which happens a lot. So right now, what we will say, and Dr. Pope, I'm not prepared for this debate, so you have a big advantage over me. But what I will say is, the mechanical data is there for the soma stimulation. If you have focal pain that's neuropathic in nature, someone just asked a question, when do you do burst stimulation versus DRG? If you have an appropriate spine and focal pain, I think Dr. Chapman, you've been a leader in the field, you agree with me on this, focal pain with good anatomy, DRG is the first choice because of the high responder rate. Gives your patient the best chance of a good outcome. If they don't have a good spine and you aren't real talented with your hands and you just want to throw it out somewhere there, you may get a good outcome. I'm not denying that, but you're better off doing it a proper way. So I think right now we need to see the initial study, and then we need to see reproducible studies. It'll take about 7 years for gutter stim to have anything near what DRG has today. And you and Chris have helped create a lot of that data. Tim Lubinau's created a lot of that data. So with that, I'll say, Chris, I wish we could have a vote of the audience, but we'll just call it a gentleman's agreement that we both had our say.
Okay, one very quick question to Tim and Ken. What recommendation would you guys make in probably 2 sentences or even 3 sentences to training programs to get the newer generation better trained in DRG so they don't necessarily feel that these type of other therapies are a viable substitute in the absence of data? Because I certainly think you've been kind of emphasizing how important technique and skill is. Do you have any suggestions that this should be integrated into fellowship training programs more frequently, or any other suggestions for the newer generation wanting to train in this?
I'll take that one first because I know Ken has trained a lot of people up in New York and at the Cleveland Clinic where he trained himself. I think all fellows should be trained. And in order for all fellows to be trained, all fellowship directors and fellowship program physicians need to be well trained. And you have to make this an art. DRG is an art. It's not just throwing a lead in, it's actually an art. So my thought would be they need to read articles like we showed earlier from pain practices that Ken published about the loop. You need to be trained in this. And if you decide it's not part of your practice, that's okay. You can refer to other people for this therapy. So you should be trained in it and then decide if it's part of your therapy. And I think that's Chris, your point's well taken, that you have to be asking for excellence of yourself when you do DRG. The lead has to be in the right place. The loop has to be made properly, and you have to anchor properly. All those things are important. Ken?
Well, I think as a fellow, if they understand how DRG works, they too should have some responsibility and push their attending to use this therapy. And all you have to do is use the therapy and you'll see why people use the therapy. So I think the onus is on the fellows and their attendings to push their understanding of what they do on a daily basis.
Yeah, and I would say one last thing, Chris. If you didn't get it in your fellowship, when COVID cut some people's fellowship short, go visit Ken Chapman, go visit Pankaj Mehta, go visit Tim Lubinow, John Carlson, Jackie Weissman, go visit some of the folks on this call, Don Sparks, Erica Peterson, go visit those folks. I mean, that's what you should do. So that's important. Very good. Thank you, Ken. That was a great discussion. Right. Thank you, sir.
Okay. So this one actually is going to be a very interesting one because I think it's a very hot topic that has been quite frequently debated. So The two gentlemen here are obviously, you've seen them lecture worldwide on the use of PNS, and they've also really been at the forefront of DRG therapy. So for all the fellows and clinicians out there that are trying to make a decision on when to use one versus the other, what do you guys think? So I'm going to let Pankaj start, and then I'm going to let Tim respond on, because obviously you guys are proponents of both therapies, but want to really hear your perspective on, is one right over the other, and when is it the appropriate indication for using one specifically? So I'll let Pankaj start first.
And thanks, Christian. I got to take a deep breath because, debating the Tim Deer with DRG, especially, and PNS, and when, I've learned from him, I've partnered with him, and I've, furthered the science with him. I think it's, first of all, it's an honor to just, be debating with him. But I'm going to start with PNS because I feel that PNS has a place, and peripheral nervous system stimulation has its place. It's carved its niche, and both Tim and me have been involved with a lot of new PNS therapies up there. I think the way I do it in the practice, I'm going to cut it short saying that I think when somebody comes in with, I'm going to divide it into upper extremity and lower extremity. In the lower extremity, my algorithm is if somebody comes in with causalgia, nerve pain, neuropathic pain, which may be focal or at least in the distribution of a nerve, which I know I can block or stimulate, and the pain is not that bad, and the patient's still functional but is bothering, I tend to lean towards peripheral nervous system stimulation with the hope that I can curb any further escalation in the pain presentation. If I'm already beyond that stage, then I triage that patient and move straight to dorsal root ganglion therapy, which we all know that by that time there's a lot of gossiping happening in the soma, as Tim says, where there's no other choice. We just have to go upstream and modulate the soma up there. In the upper extremity, the answer is pretty loud and clear in my practice, where if somebody comes in with neuropathic pain in the upper extremity, I really don't have a choice, and peripheral nervous system modulation by any therapy has really done good in my practice. So that's really my algorithm. And I will just end by saying that I'm really fond of both these therapies, and I've collaborated with Tim on both these therapies. So Tim, it's all yours.
So, first of all, I'd like to say, Christian, you have a beautiful outfit on tonight. You look very Miami-ish, getting ready for a September meeting. So Pankaj, you and I agree in a lot. I will say, you have to go with the data. And if you went with the data only, you would need DRG in everyone, because the data for PNS is coming along. It's evolving, but it is evolving. So I think I have an algorithm of treatment, which is very similar to yours. If it's somewhere from the breast down, and it's a very focal nerve pain, I'm probably going to go with DRG in most of those cases because, I know the odds of the patient doing well is quite high. If it's shoulder pain after stroke, if it's shoulder pain after surgery, if it's hand pain after amputation, I'm going to go with a PNS system first. I usually put one in for 60 days and see how they do with that. And then if they need to go perm, they can. But if they don't do well, then I'm going to go do DRG at that level as well. But I've done a lot of DRG. So for those new folks, certainly I would recommend you stay on label and not consider some of the more complex things until you've gotten very confident. But I do think that PNS is a better choice for upper extremity initially for all of us if it's reasonable. In the lower extremity, if someone comes to see you, you know who that person is, they say, well, the pain's not that bad. That's probably a PNS candidate also, because even though DRG has a higher success rate, PNS is very reasonable to try. And if they have a spine that's abnormal, let's say they have severe spinal stenosis, well, I wouldn't want to do DRG in that patient. I'd want to go to what's safest, earlier, or if they're on anticoagulation, they can't come off. Those are the things I think about when I think about PNS. So I think in this debate, we'll say we both agree. Our algorithms are very similar. You came to visit me in West Virginia a few years ago, and I visited you down in Austin many times, and I think we think alike. So I think the message for everyone is the odds are better with DRG based on success rate, probably than any other therapy if they have focal nerve pain. But in some patients, PNS is a safer option initially, and you progress to DRG if you have to. Do you agree with that, Pankaj?
Completely agree. I think that's really the algorithm.
I have a question for both.
Christian, I have one question while we're at it. I'm supposed to help you moderate this. I know I'm talking with some of the biggest innovators in the space here. You guys have really been forward thinking. My thought is there a world where, let's say we did a DRG, and I'll just put this out to both of you, but the patient still had pain. Maybe they're still on opioids. Is there a world, just based on mechanism of action, that you might actually introduce PNS as well with DRG?
Yeah, I've had John, great. I love that question. I've done both. I've had PNS systems in, which has helped some, but I've had a DRG, and I've had DRG systems in where they've been doing very well, but they've had a flare up of a nerve that's outside of where I put the original DRG. And so you could add another lead, and I've done a lot of revisions to add something if someone has disease states, but then I've used PNS trying to avoid the addition of additional DRG leads. So I think you can combine them, and I think that that's a reasonable thing to do. You just have to have a medical necessity reason to do so, and you have to explain that well in your chart. Pankaj?
Yeah, no, I agree. I've had patients who actually have a STS in, put a DRG in to kind of capture the missed segment, and then after a while, I feel like there was some neuroplasticity in the peripheral nervous system. I added a long trial of a peripheral nervous system catheter and took it out in 60 days, and then really it just allowed the DRG to work even better. And so I think there is definitely some supplementation there of therapies between each other,
Right. One very quick question. So I think this is probably something that Tim can appreciate. I think over the last 5-10 years, you're seeing really a preponderance of new therapies. Are we at the point of comparative trials when you're starting to really ask the question on specific pain indications with one therapy versus another?
Well, so I think there's 3 things we should do. I was on a webinar earlier tonight, the INS with Adnan Al-Kazi, and he said, we should do placebo trials on everyone, which is hard to do with this therapy. But, I do think that, and we're gonna have Ken and Tim finish this webinar tonight with future research, and it's important. But I do think we're at the point we should do comparative studies. The problem with that is, Chris, as you know, getting funding. Because most companies don't want to fund a study against each other, and there's no federal agency that will fund that type of study. So I would ask those of you in academics to, if you have a federal grant to do some work, that would be a great way to use that work as comparative studies, some of which has been done in Holland and Belgium to date. And I think those are important things. So I would welcome that and love that. I just don't know how we could fund the type of data collection we would need. With that, I think we're going to go over to Ken Chapman and Tim Lubinell to finish this webinar with a discussion of future research. So Timothy.
Wonderful.
So there's a number of research topics that are currently under study, and I'm just going to have Ken touch on some of them since he's been involved with many of these new projects. Ken?
Okay, so thank you, Tim. Thank you, everybody, so far. As far as research, we have, we're proving DRG is working differently and perhaps better. But we need basic science to help us prove that. We need to expand our indications, and that's through taking our small studies that we're doing and putting them together to get better data. And we need larger multi-center studies to prove efficacy for low back pain. Next slide, please. Next slide. Oh. So T12S1 for low back and leg pain, that's a retrospective study that's currently being undergone. It's got over 90 patients so far. Most of it is failed back surgery, some non-operative back, chronic low back and leg pain, some cases of low back and adjacent segment disease at S1. So you were getting a dual action there. And why does it work? We have our first image down here on the left. As we said earlier, those A-beta fibers, the neuropathic pain fibers, which are failed back surgery syndrome is going to be from, can be covered with these fibers. And remember, at points in our spine where we have convergence at our thoracolumbar junction or cervical thoracic junction, where we have convergence of fiber, placing a stimulator at just one place can cover multiple levels. S1, T12, T1, these are these spots. Next image. And at points of convergence, when you have these fibers, you can see on that blue line going down there, when these converged fibers come and we turn on stimulation, which will activate all of our inhibitory mechanisms. Next slide. We have the ability to block pain or block symptoms at these points with all of our inhibitory fibers. And where would that be good? In points of convergence. And so you think about where your referred pain is. Where do you feel that referred pain? That's where those nerves are converging. Next slide. So we'll talk a little bit about peripheral vascular disease, but the outcome so far with T12 and S1 coverage for back and leg pain really reproduces many of the studies that have been out for DRG so far. So peripheral vascular disease, I talked earlier about frequency, and how do we know? How does our vasculature know whether to vasoconstrict, to vasodilate? There's only one nerve going to them, and it's frequency. So higher frequency vasoconstriction, lower frequency vasodilation. And remember, Tim said it earlier, when we apply that stimulation, it goes in both directions. So we're sending whatever message both ways in that in the frequency in which we're sending it. And there are multiple mechanisms that are really amazing that really make placing this at the DRG special, which we could get into another time. Next slide. Here's a patient that we've treated recently, 44-year-old female. She's undergone essentially failed all conservative treatments, vasodilators. It was Viagra, I believe, all other medications, 45 hyperbaric oxygen treatments, deemed inoperable, planning amputation. She was referred for a ganglion blocks. We placed blocks clearly were not a long-term solution for her, and we need to intervene with some form of neuromodulation. And we chose DRG. It was placed at the C6, C7, and C8 to cover her lateral 3 fingers. Those are the settings. Next slide. So this thing called, don't advance the next image after this one yet, serendipity. And this patient, when she was giving me her history, said, "Hey, Dr. Chapman, I had a pulse volume recording Doppler done of my fingers, and I wasn't aware that I knew about PTCO2, but you could see here that middle digit had basically almost no blood flow, and the fourth and fifth less, 6 and 2, when normal is in the high 20s range. And this is 39, so it's probably vasoconstricting, causing her normal finger to be much higher." Next image. And so I said, well, let's put this stimulator in. You had that test on. Let's go repeat that test with the stimulator in. And you can see here, the amplitudes have, next image. The amplitudes increased, in the middle and fifth finger by 600, 700%. But I guess when you have nothing, there's nowhere to go but up. So next image. This is a patient in March after her DRG place. She was an attorney, went back to work, decreased opioids. Next images. This was her a couple weeks ago. The fourth finger is basically healed, and the middle finger is almost back. While it's been shown for limb salvage with spinal cord stimulation, it was as with other forms of DRG treatment in other indications, we find better outcomes. And there's another one coming up. Next image. Next slide. There we go. This is George Girardi's patient. We have a paper together. Hold on before you go to the next. Actually, can you just get rid of that right image? So this is a patient that had a DRG and an SCS trial. And what we wanted to, well, George wanted to see which one would potentially help this patient more. So he put both of them in. And you can see here at baseline, the PTCO2 or TCOM, which they're basically the same thing, was 3 millimeters of mercury at baseline, and then you give 100% oxygen, it improves to 15 millimeters of mercury. So then we said, okay, let's do what spinal cord stimulation does. Let's put that in first. 3 days of spinal cord stimulation. Next slide. It increased it substantially. It went from 3 to 17 and from 15 to 21. And that was pretty good. And those improvements were essentially mirrored the larger studies for peripheral vascular disease from Europe in the early 2010s and 11s, 12s. And then 3-day washout period, next image, of DRG. Look at those numbers. 55, compared to 17. Look at what normal is. These numbers are almost normalized from DRG stimulation, which is something which we see in other forms of DRG stimulation. So this is a subject that needs to be studied more, and this is something that we're going to be working on in the future. Next slide. So what about joint post-surgical pain? There's evidence out there showing that we're getting good results for patients that have post-knee replacement pain. You know, I've been kind of doing this for a while, and no one ever talked about post-knee replacement pain before DRG. Maybe 1 out of 1,000, 5,000 knee replacements, we'd really be talking about using dorsal column stimulation as a treatment on. But now we find that many people are using it. And you look at this, you know, Morgalla has a 62 patient study. Next slide. And I'm just going to quickly run through a couple patients. That's messed up. Next image. So just today I saw a 67-year-old gentleman 2 weeks out after DRG for purely mechanical pain. And I don't recommend doing these procedures until you have adequate experience when it comes to the cervical spine. I just like to say that there are inherent risks, and you want to become adequate at lumbar first. But cervical spine, 67 years old, 2 shoulder replacements, DN4 of 1 of 10. What that means is it's not neuropathic pain. You need 4+ out of 10 to be qualified neuropathic. Couldn't even move his arm at all. Couldn't go to the bathroom and clean himself. He couldn't reach it. His range of motion was basically 0, and severe pain. And we decided to put a left C4 5/6 DRG in. Next image, or next slide. This guy has 70% pain relief. I think it's more because its life is completely changed. ODI, EQ5, mood, sleep, studies, everything is better. His range of motion, 65 degrees, 70 degrees. This is what we need to be exploring. Next image. And we're just going to go along this path. And some of these stories sound crazy. 45-year-old guy, 26 surgeries, 3 knee replacements. He's ready to amputate his leg. He said, my doctor agreed to amputate my leg. DN4, 1 out of 10. We put leads at L2, L3, L4, and S1. Next, 100% pain relief. This is a guy that wanted to kill himself. And if I tell you, the guy before him told me he wanted to kill himself if things stayed the way they were. And it's terrible. But it's just people that are incapacitating pain from mechanical pain. Next. Down bottom, 5 gentlemen, 5 ankle surgeries, including ankle replacement, ankle revision. I didn't even really know about it. I was treating him for his low back pain, and in the recovery room, he said he was complaining his ankle, and I said, hey, we have this thing, DRG. Next image. And we placed the leads at the T12 for the low back, 4, 5, and 1. And again, I hate to sound redundant, 100% pain. This guy was doing absolutely great. So nociceptive pain, it's possible, and it's going to change when we're able to do this. It really will change things. Next slide. We have studies on duty cycling, which basically was mirroring Vesper's paper that Tim Deere and the rest of several of these people on the call had on with burst and microdosing burst. We essentially copied Vesper's original paper and did it with DRG. The results are still, this is still ongoing, but I can tell you that before we did this, we had patients cycled for quite a bit. And I'm sure this is going to be a very nice study. Next image. DRG is a salvage therapy, and if people want to be involved in this, it's still being put together. 2 centers. This is actually, to my knowledge, the most patients in a salvage study. There's a nice one put out by one of the fellows at Cornell, Brianka, and from her time at Mass General, which had 31 patients with Nevro. But we have 35 patients, including an additional 10 that had failed prior SCS trials. 100% conversion rate out of an average of 13 months. Essentially, only 2 out of those total 45 were explanted. And through an average of 13 months, we have minimal to low loss of efficacy with pain, function, or quality of life studies. And that is something that that all of us are getting together on. And we ask anyone that wants to be involved. Habituation, that's habituation. We are going to see less with DRG, and there's already science behind that. There's already why DRG will be better for habituation. Next image. We're almost done. Neuropathic pain. I mean, I don't even need to really talk about that. We have better access to A delta and C fibers, and we need to focus on treating things like peripheral diabetic neuropathy, chemotherapy-induced neuropathy, et cetera. Next image. And thank you guys. There's so much room to grow in this field, and it's up to all of us. Next. It's up to all of us to keep data, collaborate, in the goal of helping improve the outcomes for our patients.
Great, thank you, Ken. Krishnan?
Yeah. All right. So I think for the sake of time, we're just going to wrap it up. I want to thank all of the panelists this evening. I think the fact of the matter is that we're a little bit over, because I think each and every one of these folks spent a lot of time preparing for this, and it's a testament to how deeply rooted in belief that they think of this therapy and its implication. For the folks, just be mindful that we're going to be, obviously, we have our think tank and the annual meeting coming up. This is for the CME for this event specifically. And then next week, we have really important discussions around a lot of the stuff that's been happening all over the country, and certainly how that's impacting pain clinicians. How do we really respectfully treat each other, be mindful of our opinions, and have really good scientific discourse? But certainly it's a moment for, I think, a lot of us to hear stories from our colleagues about perseverance and really getting to that kind of that personal part of why we are in it together and collaborate in teamwork. So with that, I'm just going to let Tim sign you out tonight, and thank you everybody once again. Great job to the faculty. It's unbelievable stuff. So
yeah, don't forget to get your CME. We need CME right now because of not traveling very much. And I think Ken, Tim, Jackie, the science tonight was phenomenal. I mean, this was, you hear things sometimes that are marketing type things. This was science. So I think tonight's presentations were spectacular. So thank you so much. And I think this is really what we need to do going forward. So everyone have a great weekend. And we'll see you in September at Aspen, but we'll be back next week with a discussion of race, religion, and bias. So I think that'll be very interesting. So take care. Good night.
Thank you.
Good night, guys.
Good night.
Night.